I'm very pleased to be here. Thank you for having me. I'm going to refocus our attention right now from what we've just heard from Dr. Samir, from taking care of the child, to the mother who's taking care of the child. So what I want to do is talk about a woman's point of view from the heart of a family that has been diagnosed with Fragile X syndrome. And I want to recognize that these women and the mothers are the primary caretakers. And they're doing this caretaking in very extraordinary circumstances, when they have a child with intellectual disability and potentially behavioral problems, when they potentially have adults or older relatives that have neurodegenerative disorder, and also in a situation when they themselves are genetically vulnerable to significant clinical conditions. So what I'd like to do is talk about, again, the clinical consequences of carrying the pre-mutation, and note that it's varied and it is clinically significant. And there's issues that go across the lifespan of a female who's a carrier. In terms of, first we've heard from Dr. Haberman and Dr. Pisoni about the potential of neurodevelopmental problems that occur in children, probably those who have reduced FMRP protein, essentially showing symptoms of Fragile X syndrome. We have two important conditions that occur during reproductive life of a woman, and that's the transmission of the pre-mutation to the full mutation, leading to an increased risk of a child with Fragile X syndrome. And that is, we have to consider that at the same time as the issue of a woman who may be having infertility because of Fragile X-associated primary ovarian insufficiency, and I'll call that FXA. And then lastly, and later in life, the risk for a woman who carries a pre-mutation of having Fragile X-associated terminal ataxia syndrome, or FXA. Importantly, not all women who carry the pre-mutation have these conditions. And so we know that there's environmental exposures that might increase the risk, and we know that there's probably modifying genes. So in the background of the genes that everyone carries, the variation there, the pre-mutation may act in different ways. So let's first talk about the inheritance of the Fragile X mutation, and we heard a bit about this earlier today, so I won't go through it in detail. But I just wanted to say that first we always have to think, we know that, of course, that the FMR1 gene is located on the X chromosome, so the inheritance pattern does follow the rules of an X-linked dominant inheritance, with female carriers of the pre-mutation, 50% of their offspring are at risk for receiving the mutation. For male carriers, as Dr. Hagerman said earlier, all of their daughters will be, the mutation will be transmitted to all of their daughters and none of their sons. Straightforward X-linked inheritance. But layered onto that is the dynamic repeat expansion. So for female carriers, the risk that it's in female carriers in which there's a risk for the expansion from the pre to the full mutation, not in male carriers. That expansion depends on the maternal allele's repeat size. And this is what Rhonda was saying, that this phenomenon of the dependency on repeat size leads to the phenomenon of the observation of anticipation in the family. So with each subsequent generation, there's an expansion of the pre-mutation in females from a smaller repeat number to a larger, and with every larger repeat comes the increased risk of having a child with Fragile X syndrome. So in the younger generations, you'll see more individuals with Fragile X syndrome than the older generations. So the phenomenon of anticipation. Now this repeat size here, you can see very well that it depends on the maternal allele size. So on the y-axis is the percentage of the pre-mutations that expand to full mutations in one generation. On the x-axis is the mother's repeat size binned into groups. So for example, a woman who carries 70 to 74 repeats, that allele, when transmitted to her offspring, has about a 20% chance to expand to the full mutation. That's in contrast to a woman who has 85 to 90 repeats, that the risk of going to the full mutation and leading to an affected child with Fragile X syndrome is about 80%. I stopped the graph here at 90 repeats because those with greater than 90 repeats, the chance of expansion from those alleles to a full mutation is almost 100%. So it's again, those who receive the mutation will be receiving the full mutation. Now, we always talk about the CGG repeat, but it's not a pure repeat. Most often it's interrupted by these AGG sequences. And the more interruptions that you see in this long CGG repeat region, this more stable the allele is during transmission. So now I've taken that same graph that I just showed you, and I've now refined it by showing not only the repeat size among the mothers and their transmission going from a pre to full, but also the number of repeats that interrupts those alleles. So, for example, in a woman who carries 75 to 79 repeats, if there's no interruption at all of an AGG, there's almost a 75% risk that it will go to a full mutation. That's in contrast to when there's two interruptions, AGG interruptions, the chance that it goes to a full mutation is only something like 10%. Another example is that of those alleles, these smaller repeat size alleles between 55 and 70 repeats, the only ones that did go to the full mutation are those that you can see here in the red bars, the about 20% that went to the full mutation never had an interruption of an AGG. So this information, not only of repeat size, but of the AGG interruption pattern, gives you more information during a genetic counseling session to know the risk to of the premutation to the full mutation. Now, male carriers, as we said, the expansion to the full mutation from the premutation doesn't occur in males. Instead, there's smaller expansions and sometimes contractions. So that again leads to the phenomenon that those men who carry the premutation, all their daughters again receive the mutation, but none of them carry the full mutation. They all receive the premutation. So it's a complicated genetic phenomenon because of the dynamic repeat, but it does follow excellent rules. What are the interventions? Of course, genetic counseling is the intervention. It's important to have the family understand the inheritance. It's important to do carrier testing of the woman to give her the repeat size and the AGG interruption if she's planning on having additional children to determine the risk for passing on to the full mutation. Prenatal diagnosis and testing can be offered. And then importantly, cascade testing, or once you identify a child with a full mutation or a woman with a premutation, we know that going through the rest of the family and doing carrier testing is very important, especially for those of reproductive age who are considering having children with fragile, or having children. But let me back up and just say one thing. Typically, well, no, I'll bring it up in the next slide. Okay, so let's talk about the primary ovarian insufficiency. So how clinically significant is this? Among women with a premutation, 20% are diagnosed with POI, or primary ovarian insufficiency, and that's in contrast to only 1% in the general population. What I wanted to bring up, and maybe I should have done the last one, is women who come into into a pediatric setting because of their child with Fragile X syndrome really are not hearing anything about primary ovarian insufficiency. So the timing of explaining to her about her own health consequences is very difficult. It might not be the first session that you have with a woman who's there to ask questions about her child with intellectual disabilities and behavior and trying to get them help. They're not in a mindset to hear about their own problems. So I just wanted to bring that up to remember that might be something you talk about to a woman in a subsequent visit. How about among women with POI? About 2% of women who have no other family history of ovarian dysfunction in their family carry the premutation, or 11% of those who have relatives with ovarian dysfunction carry the premutation. And both of these numbers are statistically higher than the 0.3% that you expect in the general population as being carriers. So a very clinically significant test that should be done among all women with POI. What are the symptoms? They're the symptoms of general POI: altered cycle traits early in reproductive life, altered hormone profiles, clinical symptoms that are associated with menopause transition, and lastly, sub or infertility. So a woman who's infertile or is in the subfertility stage of her life, women with the premutation are less responsive to hormone stimulation. That's an important point. And again, an important point is that just because they have a diagnosis of POI does not mean that they can't get pregnant spontaneously. So it's very important if a woman does not want to have children, or that she doesn't want to use this diagnosis as thinking it's a contraceptive. Okay, so it's very important for that she knows that. Again, not all women with the premutation have FXA. What are the risk factors? Well, we know these three are the major risk factors: the repeat length, and I'll go into that some details, smoking, and modifying genes. So to the repeat length, here I'm showing an outcome measure being the average age at menopause for the different groups on the y-axis, and here relate to the different carrier status groups: non-carriers, low premutation carriers, mid-range, and high. I want to note that these ranges are quite arbitrary. Let me keep going and then I'll come back to it. But what you can see is those with the lowest age at menopause on average were these that had the medium-sized repeats, not the ones that had the largest repeats. So the medium-sized repeats, and this is something like 75 to 100 repeats if we look at other studies. But it's important to note that this is kind of one of those signs. If we understood why this was occurring, we'd probably understand the mechanism that's leading to the ovarian dysfunction. But again, importantly, all the women have a reduced age at menopause compared to non-carriers. So the mid-range repeat has the highest risk. Smoking in general for all women, irrespective of being a carrier, reduces the age at menopause by a year. So women who are vulnerable, those, for example, that have the premutation and already are at risk for lowering age at menopause, adding on that environmental exposure of smoking makes them even more vulnerable for issues related to infertility. And lastly, there's evidence of other background genes, as I mentioned at the beginning, modifying genes. So if you look at the evidence if you look at the mean age at menopause of the first-degree relatives of a woman who carries a premutation, if their mean age is a bit higher in general, so in like 53 or so, then that woman herself with the premutation has a lower risk of getting diagnosed with FXA. So there's clear background genes that are playing a role. Also, we found that variants that we know are associated with the general distribution of age at menopause among women who are non-carriers, those very same variants also impact age at menopause for women who carry the premutation. What are the health implications? Infertility, as we mentioned, but importantly, for women who are already finished planning their family, there's other consequences to the woman herself and her own health. Potential impact on quality of life because of the menopause transition types of symptoms, hot flushes, vaginal atrophy, mood instability, and because of the early estrogen deficiency, increased risk for early mortality, cardiovascular disease, earlier cognitive decline, and importantly, osteoporosis. So what are the interventions for this particular premutation-associated disorder? Encourage the woman to stop using tobacco. Of those women who have a diagnosis of FXA, start hormone replacement treatment. This is so important. We found in our study that 52% of the women were never prescribed hormone replacement therapy, or they were prescribed it much later in life, or they were told to get off of it, in their 40s. These women who have POI should have estrogen there in their bodies acting as protective agents as long as a woman typically does into her 50s. And then lastly, use contraceptive to avoid the spontaneous pregnancy. I just want to, so 12% of the people, again, in our study spontaneously got pregnant after a diagnosis of FXA, and they got pregnant either both ranged from getting it right getting pregnant right after they got the diagnosis to some 16 years later. Lastly, among those who have a premutation but they don't have symptoms of FAXPOI, a woman can be encouraged to keep track of her menstrual cycles, to keep a baseline, or to get a baseline hormone profile, so anti-Müllerian hormone or follicle-stimulating hormone levels, to give her an indication of her ovarian reserve. We find, at least in the United States, that the women have to be empowered to take their information about risk for ovarian insufficiency to their primary care doctors, because many times they get dismissed when they go in and saying, I'm having hot flashes, I'm really, having mood instability. And the docs will just say, just hang in there. For those who are thinking about delaying their reproductive planning, then they might consider fertility preservation. Okay, lastly, FAXTAS, much later in life. We don't know enough about FAXTAS and women. What we do know, again, if we take the classic symptoms of FAXTAS in males, we know that the onset is usually over age 55 or early 60s, and the hallmarks are the intention tremor, the ataxia, and the cognitive decline. So what about women compared to men? The prevalence is lower, the lifetime prevalence is lower in women, something like 8 to 17% compared to 40% in men. It may be milder manifestation, but there's a wide range in how it's manifested, so it can be as classic as what we see in males. So the manifestation, similar neuropathological findings, similar MRI problems or findings, but there may be a different manifestation that needs to be characterized in women. So and Rondi talked about this, the autoimmune disorders, the thyroid diagnoses, fibromyalgia. This might be all this picture of a later onset premutation disorder among women. What are the risk factors? Again, repeat size, not the same pattern as in the ovarian insufficiency. Seems to be a linear association, not the nonlinear that I showed earlier. And it seems that repeat sizes over 70 repeats prove to be the highest risk for FAXTAS. The X inactivation ratio, and again, since this is an X-linked disorder and women and all their cells shut down one of the X's, if there's skewed X inactivation where the active X carries the premutation at a high proportion compared to the normal allele, then there's an increase, there's a correlation with FAXTAS symptoms. And then the presence of other neurological disorders in the family increases the risk and severity of the manifestation of the premutation in terms of FAXTAS, again indicating modifying genes. So we've gone through the ones that are well established. We've been hearing about other types of manifestations that also may be associated with the premutation, and there's a whole list of these. Importantly, we need to understand what are the triggers of these, how do they manifest, but more importantly is that they just need to be treated. These are symptoms that can be treated, and it's important to recognize that. So the interventions, until targeted treatments are identified, treat symptoms. And importantly, for women with the premutation, they have to be recognized that they are in very difficult environments. They're doing their caretaking in very difficult environments. So there needs to be encouragement for stress reduction. For those women who present with symptoms of depression, and as Anne said this morning, you need to ask about that, or symptoms of anxiety need to be treated. And then lastly, I think it's important to encourage women to be their own advocates, to stay informed and be strong with the information that they take to their physicians. And I think having this Fragile X Society in India is one big resource for which women can tap into and get the materials to stay informed. So again, I want to argue very strongly that treating the mother, recognizing the environment that she is in, gives her an increased potential to care for her children and for her elders. So it's a very important situation. Thank you.